Today we're talking about new vitamin D data from the American Heart Association 2025. And this relates to, should we change how we optimize levels? Hello, everyone. This is an important update I wanted to share with my longevity patients, especially in those who have vascular disease. On November 9, 2025, at the American Heart Association Scientific Sessions, the preliminary results of the Target D trial were presented. In adults who already had established heart disease and a prior heart attack, personalizing the vitamin D doses to achieve and maintain a blood level between 40 and 80 nanograms per milliliter was associated with a 52% lower risk of a second heart attack over the next 4 years compared to the usual care, which would be no vitamin D monitoring or adjustment. So the key points here: over 85% of the participants started with levels less than 40 nanograms per milliliter. Nearly 52% of the treatment group required over 5,000 international units per day, which is much greater than the standard 800 to 2,000 IU recommendations by the US RDA to reach the target. The benefit was specific to recurrent heart attack, which was a composite endpoint. Things such as death, stroke, and heart failure hospitalization were not specifically reduced. This is an abstract, but the magnitude of the benefit, being 52% for secondary prevention, is striking and practice changing for those of us who routinely measure and optimize vitamin D. The full AHA press release is available in the show notes. Now, here there are 7 questions I've already received multiple times in the office and via messages that I'd like to answer about this study.
Does this mean that everyone should aim for 40 to 80?
I think in my patients, I actually like a 50 to 80 nanogram per milliliter range. And this is something which I've been doing for years, especially in patients with established coronary artery disease. I would expect meaningful protection when levels are kept in that range. For primary prevention, which means no known heart disease, we don't yet have equivalent randomized data, but there's no reason to not optimize one's vitamin D.
I'm already taking 4,000 or 5,000 IU daily, and my level is only 35. Should I increase the dose?
My answer to this is yes. There's not a reason not to put it into the 50 to 80 range, even if you do not have any coronary artery disease, but especially if you have some vascular disease. It would seem to be a very sensible thing as far as risk reduction of having an event, even though this data was specific to having a second event. Most of the time, we're safe up to about 10,000 IU per day, as long as things are monitored. And we don't want to overshoot, but it is something where when we're monitoring, we're fine doing that.
Is there a risk of taking too much vitamin D?
Yes, there is. It takes about 3 months to get a stable vitamin D level once changing what your supplements are. It's also reasonable to take a look at your serum calcium along with that every 3 months. Doses in this study were reduced if levels went over 80 nanograms per milliliter, because I doubt that there's much health benefit to going over that, or if the calcium became elevated. So as long as we surveil your blood levels, rarely to get any symptoms less than 100 nanograms per milliliter, and even 150 nanograms per milliliter almost is unheard of having any significant side effects, but certainly needs monitoring. There's no reason to go over the 100 nanogram per milliliter.
My cardiologist says 30 is sufficient. Should I still push for more?
Absolutely. I think based on this data, which is from the American Heart Association, it would seem as though for secondary prevention of heart attack, the evidence suggests that a sufficient dose should be one that ends up getting you in the range of 40 to 80 nanograms per milliliter, and I prefer the 50 to 80. So I would recommend increasing your dose in the event that that were to happen.
What about people without heart disease? Any takeaway for longevity patients?
Yes, I think that for everybody, the biggest risk of death and disability is vascular disease. So things that would tend to decrease a second event probably decrease a first event also. So it would seem pretty reasonable to keep ourselves in the 50 to 80 nanogram per milliliter. And I think for doing that long term would be a very sensible thing in general, including for osteoporosis.
Should I switch to weekly or monthly high-dose regimens instead of daily?
Daily and every other day dosing gives much more stable dosing and blood levels than doing it weekly. And in general, the Target D trial looked at doing it daily. So I think in general, I would probably just stick with doing it daily. But ultimately, a weekly dose will oftentimes get a stable long term dose, given that this is a fat soluble vitamin.
What exact protocol will you now use in your practice?
So I think measuring the 25 hydroxy vitamin D along with serum calcium at baseline, and if less than 50 nanograms per milliliter, we'll end up doing something, usually a supplement, in order to increase your vitamin D3 on individualized dosing. And then usually we're going to want to recheck about 3 months, which is about how long this takes to stabilize, as it is a fat soluble vitamin, and then titrate the dose to maintain in the 50 to 80 nanograms per milliliter long term, with then annual or twice yearly monitoring once stable. And this would be for primary prevention, longevity patients. Um, I think that we just continue doing this because it makes a lot of sense as far as diminishing rate of vascular disease, but also, as I mentioned earlier, osteoporosis is another thing that this will end up helping. So this is the update. And if you have established heart disease or your last vitamin D level was below 40 nanograms per milliliter, please schedule a lab test or telehealth visit with me so we can review and adjust this safely. Stay well until next time.